Okay, everybody, I'd like to welcome you back to a really exciting session here. We have an Ask the Doc session, so it's going to be open to questions and answers. They're not going to give you a presentation first. They're just going to answer all your unanswered questions from the conference. I'd like to introduce them first. So I have Dr. Mark Warren, Dr. Michaela Rubin, Dr. Lynn Kohlmeyer, and Dr. Michael Manstadt. If we could give them a quick round of applause and thank them for doing this. Do we have any questions from the audience? Anybody from the audience that would like to start us out? Okay, I'm going to start with a question that came in online. If you know you are a stone former and the stones aren't moving or bothering you, is there any need to keep testing?
Keep testing what?
I don't know. That is what all the question says.
Good. Yes, you should continue testing. If you meant the urinary calcium, definitely, or stone profile, because the biggest risk for forming new stones is if you had already a stone. So if you have a stone or had one, you're at way higher risk than the normal population to develop more. So you do want to have a stone profile 24-hour urine. You do want to see a urologist. And with regards to visualization, scanning, ultrasounds, CAT scan, that you want to leave to the urologist who would tell you. Typically, they do at least annual imaging.
Okay.
Can I add to that?
Yep.
I also think it's important to know whether someone's made a stone in the past, because people, believe it or not, forget, or, oh, it was when they were pregnant, or it was, and if you've been able to make a stone, in my opinion, that's a bad sign. That means likely calcium monoxalate can precipitate into a stone. And then if you already have a stone on imaging, so if you've made one in the distant past, even if it was 20 years ago or more, I'm going to want to look at your kidney with an ultrasound or x-ray. And if you have a stone, it can get bigger. It's kind of a nidus for more calcium to, add on to it. So we absolutely care about that.
I would say in the south where I live, it's the stone belt anyway, so people have a lot of stones even if without hypopara, so if some hydrate.
Okay. Are there any recommendations for osteoporosis for hypopara patients?
So we know that hypoparathyroid patients tend to usually have thick bones, kind of the opposite problem of osteoporosis. But there are certainly hypoparathyroid patients who have osteoporosis and thin bones. PTH is interesting in that way because it can actually help bone building. After all, Forteo is an osteoporosis medicine. So you could think that a hypopara patient with osteoporosis would actually benefit from being on a PTH therapy like Forteo. On the other hand, PTH works by kind of moving calcium from the bone into the blood. So there could also be some bone loss with PTH treatment. And that might depend a little bit on the spot in the skeleton you're looking at. PTH might prefer to remove bone from the arms and legs, what we call the cortical bone, more so than the spine or the hip. It might also depend on whether somebody is getting a continuous PTH like TransCon, which theoretically at least might lead to a little bit of more of a decrease in bone as opposed to something like Forteo, which isn't an around-the-clock normal level of PTH. So I think all those things need to be taken into account. Usually I avoid using a medicine which is known as a bisphosphonate like Actonel or Fosamax, or especially a stronger anti-resorptive one called Prolia or denosumab, because those medicines work to kind of lock calcium into the bone, and that could be a real setup for somebody to develop hypocalcemia that could become difficult to treat.
I can add to that. That's excellent. I'm hoping in the future, if we have parathyroid hormone replacement for hypoparathyroidism, not only can you forget about your hypopara, which would be fantastic, if that's the case, then maybe we have a new playing ground where we could treat your osteoporosis as if you didn't have hypoparathyroidism. And I don't know that, but it makes sense.
Michelle, I have a question back here.
Okay.
I have a question. Over the years of having hypopara, I've seen several different endocrinologists, and some of you guys recommend increasing calcitrol over calcium and vice versa. I was just curious your thoughts on that.
Yeah, I'm sure we all have opinions about it, so it's good to have several endocrinologists tell you what they think. Well, first of all, there are sometimes clear rules in medicine, sometimes there is room for different opinions, and I think this is one of these examples, right? And you've heard many talks today and yesterday, they were slightly different, right? You get a little different slant on things. And so historically, the United States were famous for giving a ton of calcium as opposed to calcitriol. In Europe, hypopara patients were treated with much more calcitriol and very little calcium. And so in my opinion, first of all, people should take about 1,000 or 1,200 milligrams of calcium anyway, with or without hypoparathyroidism. And so I target that for hypopara patients too, and often they need a little more, but I rarely go over 600 3 times a day. If somebody is on 2.5 grams of calcium, I want to increase the calcitriol. The flip side, of course, is that one of the few ways of lowering serum phosphate is by calcium binding the phosphate in the food. And so you don't want to decrease the calcium and increase calcitriol in those with high phosphate levels, right? There you need the calcium.
Okay, going back to the question about osteoporosis, someone wants to know if you're already on PTH therapy as you enter menopause, is there extra precautions you need to take to protect your bones?
I think we would certainly advocate for calcium sufficiency, which, would be taking at least 600 milligrams a day, or probably more like 1,200 milligrams a day. I think you'd want to have your bone density monitored. But I think those are the recommendations that I would have for that.
I think to add to that is what we all need to remember, which is to be active, to not fall, to work on your balance, to work on your core. You don't have to have osteoporosis to not think about that. We have to think about that from the beginning. And the more you load your skeleton in a safe way, the more bones you build as you're growing, and then the more you do that, the more you maintain them. Of course, you have to do it safely, and you absolutely don't want to use a trampoline. That might be great for kids, depending on where they fly off, but it takes away the impact. It's dangerous. There's no trampoline recommendations.
Or helicopter skiing.
Otherwise, we want you to be active and love life.
There you go. Michelle, we have one in the audience here. up
Okay.
front.
Hi, thank you. Hello? Hello? Oh, good. Hi, I'm John. As a stone former with high phosphate levels, my endocrinologist is not as informed, and his counsel was drink water. I'm here today. I learned I should increase my calcium and take it with food to bind with the phosphate. So far, so good?
Increase the calcium is not quite right. If you decrease the calcitriol, the question was, what is the relationship between calcium and calcitriol that you take, right?
Right.
So if your phosphate is high, I would probably not decrease the calcium amount that you take, but rather the calcitriol.
Okay.
Thank you.
Now, here's the big question. That was my context. The question is, everybody says, take your calcium, perhaps distributed through the day, but always with food. So here's the question. It's actually my wife's question. How much food?
I'm looking at obesity here.
And I'm sorry that I'm talking
under the
again.
bus.
I had the same question actually just in the break. So it's actually good that you questioned that. My opinion is we're not saying take calcium with food because calcium is better absorbed or it's better for the calcium or for the stomach. It's the other way around. You want to bind the phosphate in the food. So if you have food, take your calcium with that food. It's not like we force you to eat more. No, no. Good, yeah. So if you have 3 main meals, breakfast, lunch, and dinner, right? Take your calcium with these. Because I have patients who come and say, well, I thought I should take it outside of food on purpose. No, no, no. Take it with food because it binds the phosphate. But if you, let's say, you don't have breakfast or very little, and you say, well, somebody told me I should take it with food, so I eat more. No, no, no. Just take it then without food if you don't eat in the morning. But then you don't have, and actually I should leave it like that.
But we do need to know your urine citric acid level and your urine oxalate and what kind of stones you make. And do you add 2 cups of lemonade? Has your urologist, endocrinologist, or nephrologist given you UroCit-K to raise your urine citric acid levels up over 600 to reduce stones? So all that, has a lot to do with your taking your calcium.
Okay, Michelle?
Okay. Can hypopara cause dizziness or lightheadedness when labs are normal, or is this more likely to be related to my thyroid? Who wants that one?
I would say it's more likely related to your thyroid if your TSH is low and your thyroid's high. That's one of the main reasons for that. But you could have low blood pressure. I mean, those kind of symptoms, you need a workup unrelated to your hypopara, and that was one of the messages of several of the talks is, we all tend to understandably blame low and high calcium for everything because it usually is why, but we don't want to miss something else, and so we always need to make sure that we're looking for something else. So you might need an EKG or a Holter or, orthostatics. And
If somebody is on PTH, that does have a small chance of causing dizziness or lightheadedness.
And usually that's within the injection, maybe half an hour after the injection.
Okay, thank you. We have one from the audience.
I'm on the Transcon, but nobody's told me to continue to take calcium just as a daily supplement. Is that something we should be doing on Forteo or Transcon or? 'cause
Well,
no
that was
doctor's
my
told me.
question, and in the trials, they assume, but it's our job to remind our participants that they're still getting 1,000 to 1,200, that's what the protocols say, of dietary calcium. I think that we would be happy with 800 milligrams of dietary calcium because you get a few hundred with vegetables. But what's also really important that's related to your question is to keep taking D3, because if your 25-hydroxy vitamin D level drops anywhere below 20, I mean, usually we want it at least 30, then your parathyroid hormone replacement won't work as well because you can't convert that into 125 dihydroxy vitamin D or active D.
So we should keep track of like how much milk or drink and dairy, so that would be part of the 1,000 or 1,200 in your
Yes.
daily? Okay, thank you.
It's almost impossible to get 1,000 milligrams without having some calcium supplement. You've got to eat a fair amount of dairy. So usually, most people go around 500, 600 milligrams a day just without any dairy products at all. So, but it's hard to get 1,000.
Especially for those of you who are vegan. So, I've had patients become vegan 2 to 3 years later and kind of forget about their calcium and vitamin D. And so, if you can take fortified orange juice or fortified vegan granola bars, whatever you can find, but you have to look.
For those that are on PTH therapy, though, and if you can't get it from the diet and your calcium is already running at, say, 9.3 to 9.6, where a lot of the Transcon patients are running, would it really be wise to continue taking supplements? Because that might put
Yeah,
you
I
over.
think the USRDA, says that we should be taking, at least 600 milligrams a day. So I would recommend that.
All right, Michelle, why don't you do a few questions online, and then we'll go back to the audience.
Okay. Let's see. Should women take extra calcium their entire cycle or more just on the heaviest days?
You have to try it out. You have to test it, right? And then if you do have monthly symptoms of low calcium, ideally even measured, then you want to take extra calcium during that time. And how much and how long, only you can try and tell.
Okay. I am post-surgical. My PTH is 7 and stays normal. I'm on 1 calcitriol and 1,000 milligrams of calcium, but my phosphorus continues to be high. Are there any recommendations?
With the calcium is 7 and
The PTH is 7, it says.
and the calcium is
And the calcium is normal. They didn't give an exact number.
And they didn't tell us how much we need
Right.
to know how much active D too.
yes. So you need a lot more information. But the general answer is that taking calcium 3 times a day with meals, or adding calcium with every meal that you're having, without increasing your meals, is a good way of binding some of the phosphate. And then if the phosphate is still high, and if you're not a child, because children have different normal levels of phosphate, then it is a little more difficult. And I typically have a nutrition consult, a nutritionist see the patient, because some phosphate is ubiquitous, it's everywhere, right? It's hard to avoid, but some food have a little more, and it just happens to be the one that I like, so chocolate and nuts. And I also told you the spinach, right? So you can look it up and see what you typically like to eat, and if it's that high of phosphate, you might want to reduce that.
Good answer. Okay. Is there any alternative to calcitriol if it upsets your stomach?
Cricket.
Nobody knows.
Not in the U.S. Canada there is. Yeah.
Okay.
You can take high doses of vitamin D, but it's like 50,000 units a day, and you can quickly get hypervitaminosis, so it's...
Not recommended. Okay. I'm currently in the NatPara Special Use Program that will stop by the end of 2024. And my endo wants me to switch, but is not sure whether TransCon Early Access Program or Forteo would be a better option. Any suggestions?
I would prefer TransCon over PTH.
I would too. Forteo's too short acting. You have to take it twice a day. It'd be more difficult to get approved. So I think that the TransCon Early Access Program.
Michelle, we're going to take a few in the audience.
Okay.
Hello, my question's a little different. When you have osteoarthritis pain, is it always due to arthritis or can it be due to hypopara?
It can definitely be due to hypopara as well.
But it doesn't have to.
It's hard to know. I mean, that's where you see your doctor, see a rheumatologist, hopefully avoid steroids and prednisone, but do everything else, physical therapy, nonsteroidals if you tolerate them, maybe topical nonsteroidals, all those things that you don't really think might help, but they might, exercise, stretching, and then try to make the difference. I think, my patients in the trials on TransCon and AZP, their arthritis and their fibromyalgia pain went away in days. Now that's, just a few here and there, but it's awfully good to hear. So it's usually a combination.
And it's one of the actually real problems, and that is when you have hypoparathyroidism, it doesn't protect you from having osteoarthritis and osteoarthritis pain. Could it be related? Nobody can really be sure, right? And so how do you decide, oh, this is totally independent of hypopara, it's just my osteoarthritis like many other people have? It's really a big problem. And, trying for instance, if it's the calcium level, and try different calcium levels. See, does it change with my calcium levels? And if it doesn't, maybe it's not related.
You're up.
So my question is actually kind of piggybacking off of that question. It's kind of funny, we were all thinking the same thing. So I'm only 31, and I recently got diagnosed with osteoarthritis in my shoulders. And so I was wondering, has there been any research, because I know that hypopara patients tend to have thicker bones. Has there been any research into if that contributes towards bone spurs or osteoarthritis?
Well, bone biopsy studies that we've done show that the bone is overly thick and hypermature because it's very slow to undergo the normal bone replacement that healthy bone does. Anecdotally, a number of my hypopara patients do have osteoarthritis, but I'm not aware of studies that specifically looked at manifestations of osteoarthritis.
But now I have like 6 questions, but I'll let. But I do have fibromyalgia, and I saw that it was compounded with the hypopara, but nobody else did, and it was all unrelated, and neither of my doctors would touch it with the other one. Fortunately, I got cancer 3 years ago, and with the chemotherapy, it just seemed to knock it out. Well, the chemo, because it's against the autoimmune, so I had no pain until I started healing, and then it came back. And I went vegan, and that helped the inflammation. So I drink lots of kale smoothies. So I get lots of calcium that way. But someone just brought up the spinach about oxalates, and we need to stay away from oxalates. So spinach, rhubarb, I just looked it up, but a couple of steps. So maybe you could either talk about that or the connection with fibromyalgia, but you've already answered that.
Okay. When and for how long after diagnosis do we need to continue to test our PTH?
Well, the guidelines where most people here have been part of, they say typically if you had hypoparathyroidism for 12 months following surgery, it's likely to be permanent. Now, there are always exceptions, and there are very few patients, some are even published, who recover even later. But so if the hypoparathyroidism has not changed after 12 months, you probably don't need to, you should not expect that it will.
And one of the reasons that kind of came back at us for the trials is you need 2 parathyroid hormone at the same time as a corrected calcium historically in order to qualify for the trials often. And we don't continue to measure parathyroid hormone. So sometimes we have to remeasure it if we can't find that combination.
Is there any research that you know of that shows the percentage of post-surgical hypopara from neck surgery? Like what's the percentage of neck surgeries to hypopara?
Overall, and it really depends on your community, the expertise of your surgeons, whether you have had Graves' disease or a bigger gland, or whether you've had there's so many reasons. Obviously, a more complicated neck surgery is going to increase the chance of hypocalcemia, usually, thankfully, temporary. But I think the number that I remember is 6 to 8% of all anterior neck surgeries ends up in chronic hypopara. Now, when we were in training, and what the surgeons will tell you is that it's less than 2%, and that might be, we hope that's the case at high volume centers. But transient hypocalcemia and hypoparathyroidism can be as common as 20 to 30%, but it doesn't last. So those are the numbers I remember, but I'd love to hear everybody's opinion.
I think, yeah, it might be a little bit lower, like on the order of, 2 to 5%, I think, in the hands of experienced surgeons, the permanent hypoparathyroidism.
And I have a question for clinical trials. Dr. Warren, if somebody comes in and wants to be a part of a trial, but they're not like in the correct ranges, how do you go about getting people, what do they do? Like, how do we know if people are in the correct ranges for a clinical trial? And then how do you get them there?
It depends on the indications or the inclusion criteria of the trial. And for example, the thyroid function has to be normal in most of these trials, and you have to have the stable dose of 6 weeks prior. And so if they know what their TSH is prior to that, recently, that would be helpful. And if you look on the trial site, you can sort of see what the inclusion criteria are as far as the calcium trial and calcium supplementation requirements are. So that's helpful. And again, if you know what your TSH is before going in, it's helpful. And if it's suppressed, you have to change your dose, and it has to be stable in the AMULET study for at least 6 weeks.
Okay, very
And
good.
in addition, the vitamin D level should be normal because that takes time to increase if it's too low. And then most trials have, or all trials have, an optimization period, right? Once you sign up, there's time to optimize your numbers such that you qualify to go forward. But typical things that take time is the TSH and the 25-hydroxyvitamin D level.
Some studies require being off a thiazide diuretic for a certain amount of time beforehand also.
And it's such an important question because if you live far from the site, doesn't mean that you can't still be part of the trial, but you want to try to have your labs as smooth as possible, which is difficult with hypopara. But for the most recent hypopara trial, you want your vitamin D to be over 30, so you might need to up from 2,000 a day to 5,000 or 10,000 for a period of time, but you don't want it to be over 80, you don't want to overtreat. And if you've had thyroid cancer and you've had suppressed TSH on purpose from your endocrinologist, in order for the trials, it has to be at least 0.2 or higher. So that's still 0.4, 0.5 is usually the bottom of the normal range, so you can still have slight hyperthyroidism. And if you've never had thyroid cancer or you're finished with that suppressive period and we want your TSH to be normal, we know how hard that is with hypopara and all the calcium. So for this trial, it has to be 0.55 to 7, or 1.5 above the normal range, about 7.5. And then as you're on parathyroid hormone replacement, whatever trial, and your calcium drops, you're going to need less thyroid, a lot less thyroid, because you're absorbing it so much better. And so you really need to watch your TSH every 4 to 6 weeks, as Dr. Dolores Schoback showed us, so that all of a sudden you're not hyperthyroid and didn't realize it. But getting all that done before your first screening day, because then you only have really 2 months. And we don't want you not to be able to be in the trial because we didn't do a good enough job getting things perfect before.
So I think communicating with the study site beforehand and trying to get as much of that done, where we can't tell you what to do before you sign a consent form, but we can tell you it would be a good idea if you work with your doctor about changing your dose. I can't change your dose in the meantime. I can't really tell you anything, except that it would be great if you could work with your doctor and get these things, these labs done.
And working with your doctor is key here, right? Don't change everything just because you think my numbers have to be like this. Has to be supervised by your physician.
Go ahead, Michelle, real quick.
Okay. Why is it that the new drugs we see coming into development don't use the whole PTH molecule? Can you explain why that part of the molecule is not needed?
The question, what's the difference between PTH 1 to 34 and 1 to 84 is the full length versus the fragment that is active, has stirred lots of discussion and some research, and to the day, I have not seen any convincing data that shows us why there is this longer molecule. And for practical reasons, it's much easier. If you know all the activities in the first 34 amino acids, you take this one and modify it instead of having this long peptide.
One advantage of the 1 to 84, the full peptide, was that it did last a little bit longer than Forteo, the 1 to 34. But now that hopefully we're going to have other options that last even longer than the 1 to 84, which maybe lasted like 12 hours, now we'll hopefully have 24-hour long ones with TransCon or the AMULET drug. So I think it kind of obviates that point.
I got a question. It's more about the PTH while on one of these, Natpara, one of those medicines. Now, when I was on Natpara, I think in the very beginning, and one other time, went up to 11. And at the beginning, it went really high. Now, I'm non-surgical, so no parathyroid glands. Should it happen that when you're on these, whatever medicine it is, the one of the PTH, should your parathyroid go to normal range, or those without the parathyroid glands? Is it typical that we stay low still, even with the medicine?
I mean, when we measure PTH with the blood test in the blood, that's detecting the whole PTH, what we call the 1 to 84. So if you're taking, unless you're taking PTH 1 to 84, which is net para, if you're taking any of these other PTHs, if I understand your question, like Forteo or Transcon, so then your PTH would still be low because the blood test wouldn't be measuring that.
Okay. Someone wants to know, do any of you have any opinion of the new clinical trial that's being run here in the U.S. regarding allotransplantation of parathyroid?
I know that's a study that Dr. Schobach is leading. I don't know if you guys know more about it, but it sounds very promising and very exciting. I don't know the details of it, but I think, the hope is that it could be something like a cure. It does involve transplantation, and I think it does involve some degree of, at least at first, immunosuppression. But it does sound kind of like a potentially exciting new possibility.
Okay. Is there a difference between calcium carbonate and calcium citrate? Which is recommended, or can you mix the two?
It's a good question. There's a lengthy answer to that. So some people, for calcium carbonate to be absorbed, you need acid in the stomach. And if you take medications that suppress acid, like omeprazole, calcium carbonate will typically not being absorbed. So if you're on an antacid, like omeprazole, or you have other reasons why you don't have enough gastric acid, you have to take calcium citrate. And calcium citrate, as I tried to explain, has little, you need more tablets basically for the same amount of calcium than with calcium carbonate. And there was a recent study that seemed to indicate that calcium citrate has less constipation effect than calcium carbonate. It was one study, so it's hard to tell. If you're elderly, then often there's not enough acid in the stomach. And so then you might actually want to have calcium citrate instead of calcium carbonate.
And you can combine them. I think what you don't want to do is just take, which I know you don't, any calcium off the shelf that might have a whole bunch of other things in there, because you're taking more than the average person, and you don't want to get too much boron or zinc or whatever marketing, vitamin K, just don't believe any of that. Don't take it, unless we have a study to prove that it's safe and that you need it. Now, we haven't talked about magnesium yet. I know there's a lot of good questions and comments, and you guys can probably teach us more about that. But if there's magnesium in your calcium and you're taking more than one, you don't want to get too much magnesium either, even though you might need some. So that's why for you it matters what calcium you're taking. And you obviously want to tolerate it, and you don't want it to be a big tablet you hate swallowing. So we want to try to find the best calcium for you.
The calcium you hate the least.
Well,
All right, we have a question back here.
So I've lately been hearing anecdotal from several people who have been long-term hypopara that they're weaning themselves off their calcitriol and finding that their PTH is coming up. One person that I recently talked to online is like 16 years out like I am, and they are recovering PTH.
So I'd be very careful with that. A lot of people may have partial hypoparathyroidism, which is kind of what I talked about before, and I think that that can still, it doesn't mean mild hypopara. It's almost, it's like being partially pregnant. No, you're hypopara or you're not. You're pregnant or you're not. But I think, I'm guessing that in that situation, if you're able to taper off calcitriol, you've got parathyroid function. I mean, I'm not guessing, that's obvious. So I'd be very careful. I think if your parathyroid hormone was ever less than 10, and your calcium at that time, maybe, I don't know where we would say, let's say it was less than 8.8, I wouldn't try that ever. On the other hand, if your parathyroid hormone, when your calcium's less than 8.5, bounces up to 20, even though you're hypopara, then that shows that you have some function. But be very, very careful tapering off of Active D without your doctor's guidance.
I don't have the mic anymore, but did the testing for PTH improve within the last 6-ish years? Because I was always undetectable, and now I have like 6, and stuff, so.
Well, the Intech PTH assay's been around probably a good 10 years, I think. So I don't think it's changed the last 5 or 6 years.
When there are different companies,
Yeah.
they use slightly different antibodies, and they have slightly different normal ranges. So maybe the detection limit has changed a little bit, that they can detect something that they were not able to detect before.
And your lab may have been using one assay and they changed to a different assay.
And that reminds me, I don't know if we've mentioned biotin, right? So the assays use biotin to measure these hormones. Everyone needs to be off any biotin supplement, and it can be in something you don't even know it's in, not usually calcium, but a multivitamin, for at least 3 to 7 days. I say 3 to 7 days, but before you get your labs done.
Just to qualify this, high dose, these mega doses of biotin. If there's a little bit of biotin in the normal multivitamin, it does not interfere. And even if you're on mega dose of biotin, most PTH assays in this country will not be influenced by it.
But the TSH
But
is.
thyroid.
TSH, yes. Oh, definitely. TSH, you were talking about PTH, right?
We were, yeah.
We were
Yeah,
talking
yeah.
about-
Oh, TSH is totally different. There, you really want to be off of it.
Okay, do we know if any of the PTH drugs that are being worked on are safe during pregnancy?
We don't. But of course, every pregnant woman has PTH around, right? But it's officially not recommended to take during pregnancy.
So would you recommend or not recommend starting on something like TransCon if you planning on becoming pregnant in the next few years?
Since we are on live microphones and on the ether, the recommendation is not to start it.
I would add that people who are pregnant usually do better with their hypoparathyroidism while they're pregnant. As Dr. Manstad alluded, the body is making PTHRP, which functions almost identically to PTH, and the placenta also makes calcitriol. So actually, for most women, of course, there are exceptions. Pregnancy is a time where the hypoparathyroidism becomes much more mild. And obviously, it's very important to be closely monitored by the doctor because the baby will be affected by the calcium level. So if the mom's calcium level is too low, the baby can have hyperparathyroidism, or the opposite scenario could also happen.
All right. Well, thank you so much for all 4 of you participating and sitting in the hot seat up there. I wanted, before we close, is there anything else you'd like to say to the group before?
I'd like to say a couple things. I want to thank everybody, first of all. This has been an amazing opportunity and experience for us, and I've learned so much. There are some medicines, and maybe we can add to this, that you shouldn't take if you have hypoparathyroidism, and we haven't brought it up yet. And one of them is Wellbutrin. It's a great medication. I've never prescribed it. I'm an endocrinologist, but it's for anxiety and depression. But it has a low seizure threshold. It lowers seizure threshold. And so if you are hypoparathyroid and your calcium might drop, you don't want to be on Wellbutrin. So I just wanted to make sure we all knew that. And there are other medicines that lower calcium, and you mentioned bisphosphonates, but I think that that's important to know.
And I would echo, it's a great meeting. I appreciate the invitation to be here. Be patient. We have treatments are coming.
Very good. All right.
Well, thank you all very much.
Thank you.
All right. All right, so Michelle and I are going to close things out here for today. And really thank you all for participating and all the knowledge that you've shared with us. So, oh, I guess I can use this now, right?
Yeah.
Okay. So really, we just want to close things up with I talked to you a little bit about everything that we did this past year and things that we're going to be doing moving forward. But I do want to take another second to really recognize this one right here, because she has put her heart and soul into this organization this last year, and that website that we have is just amazing, and I want her to talk just a little bit more about it, and the PFDD coming up. So take it away.
Thank you. So if you haven't checked out our new website, I'm hoping everyone in here, that's how you found out about this event. But I encourage you not just to look at it for events or the homepage. We have a lot of new great resources that I've done a lot of work on our new website. So explore around. Don't be afraid to click, and don't be afraid to ever email me and ask where you can find something if you're having difficulty, because that's the only way we're going to know how to make the website better or easier to navigate. We have some great new resources on there. We've partnered with some new foundations. One of them is the Patient Advocate Fund, and they help you find resources for getting your drugs paid for, resources for fighting with your insurance, different things like that. We've also partnered with a company called Aimed Alliance, which has written a wonderful pamphlet that's on our website about explaining to you what some of the terms you might see from your insurance company, especially when a new drug comes on the market like TransCon PTH. You're going to see words like prior authorization, step therapy, different things like that. I encourage you to learn about those things before the time comes, and then you're so overwhelmed and frustrated and you don't know what the next steps are. I really encourage you to explore those items and then reach out to the association. We might not have all the answers, but we're certainly willing to help you find the answers, okay? So I want to encourage that and explore. And if you have a really great endocrinologist, please go on the website and recommend them. We have a new map that shows where those endocrinologists are. We've been getting some recommendations for other countries, so all those people watching online, please, if you're in another country, recommend your endocrinologist if you have one, so that your fellow hypopara warriors can find that same person. So that's a little bit about the website, and I'd be happy to talk to anybody afterwards about if you have more specific questions about it. But my passion for the next year is to encourage you to be a part of the change you want to see in the hypopara world. And part of being that change is advocating for yourself, that's obvious, but we're going to have a lot of things you're going to see in this next year, where I'm going to ask of you to share your testimony and help us make a difference for more than the 1,900 of you that follow us on a regular basis, okay? So things like the PFDD, and some of you may or may not have seen my previous video about what is a PFDD. I'm not going to go into the whole video, but I will share a little bit. It stands for Patient-Focused Drug Development. Thank you all, I lost my wording. Patient-Focused Drug Development. It is a really big meeting. We started working on the application last year. We turned in the application in February. We went through all the things and finally got our approval to have the meeting sometime around April. And our meeting date has been set for March 5th of 2024. I am excited to tell you that we have to have 2 panels, and we have selected those panelists. Some of them are in the room. Raise your hand if you don't mind being recognized. We have some panelists in the room, and we're super excited for them. But on top of that, we still need the rest of you to join in this fight. And maybe you don't understand the purpose of what we're trying to achieve with the PFDD. There's a lot of things we're trying to achieve, but one of the big focuses is we want the FDA, as well as researchers and other people that will read the paper that will come out of this, to understand that this is not a hypocalcemia problem. This is an endocrine problem. And until they start to see this as an endocrine problem, they're not going to want to pay for treatments that treat an endocrine problem. And so we're going to need your help to make that, our focus and to make them hear our voices. So one way that you can help is look at when that meeting is and plan on being there, whether it be virtual, because it will be live streamed with my good friend John over here. He's going to help us again. And it will also have an opportunity if you live in the Washington, D.C. area. It is going to be in Maryland, but is close to Washington, D.C., about 25 minutes outside of the downtown D.C. area. So anybody that lives in this area, I would encourage you to come and attend the meeting in person, because they will listen to you. There will be an opportunity for people to speak and answer questions. So I really, really want to encourage that. But mostly, I really, really want to encourage you to do what you can, whether it be give 1 hour a month to the HPA organization, or just simply send me an email with suggestions, because it is helpful. It gets tiring to be the only one to come up with ideas. So I'm not saying that the rest of the board doesn't. I mean, the board, we're small. For those of you that don't know, the board is only 6 people. We do all of this with the power of 6. And we each have things that we specialize in, and we can definitely use your help. But change is not going to happen for our greater community if we don't all participate. And with that, I'm going to leave it at that.
Thank you, Michelle. All right, guys, so here we are. We are at the end, but I did want to also recognize, could I have my board stand up? I have Deb Murphy. Thank you so much. Stand up and remain standing. I have Loretta Gully back there, who's done a fabulous job as our secretary. I have Bob Sanders over there serving as our president. And I would like to ask anybody that's in the room that's a caregiver, if you guys could please stand and remain standing. Thank you for being here today. If I could ask anybody in our medical community that is here to support us, if you could please stand and remain standing. Our medical advisors, our physicians, our doctors, our pharma, everybody up. And then if I could have our patients please stand. All right? Look at this room. It takes all of us to be part of the change. And for you guys online, stand up in your seat and be a part of the change. Thank you, everybody, for being here. Have a wonderful rest of the day, and we'll talk to you soon. Thank you.